Welcome to Healthcare for All's second Wednesday speaker series. Tonight, Brad Finegood from Public Health Seattle and King County will lead us in the discussion on pathways for recovery for people with substance use disorders. We want to offer your ideas on these steps, or to find out what ideas you can offer on how we can support these steps to recovery. The new laws that were passed this summer that classified public drug use and drug possession as a gross misdemeanor are still in the news, and we don't know how that will impact criminalization of drug users. So we want to be able to get your ideas, and we want to build ways to overcome the barriers that stigmatize substance use disorders. My name is Ronnie Shure. I'm a retired pharmacist, and I volunteer as president of Healthcare for All Washington. Thank you for joining us tonight. You can volunteer too. Please consider doing that. We have a policy committee, a communications committee, and our third wing is a fundraising and outreach committee. You can find, if you look in the chat, you can see that we're posting our website. We're actually posting the donate button. When, if you can, we would welcome donations that help make this work successful. And then you can rotate or navigate to the Get Involved button, the icon at the top of the page, the main page, and that'll give you access to volunteer, volunteer with us. So every donation makes a difference. We've set a goal to raise $250 during this program. So as you see the message show up in the chat, please feel free to take a break and go to that link and think about volunteering with us, getting involved. We also want you to put your questions in the chat. We will track those questions, and at the end of the main presentation, we will turn to those to a Q&A session. And we have enabled the closed caption icon, so you can hover over the bottom part of your screen. You'll see an icon that says closed captions, and if you click on that, you'll be able to show our words immediately on the screen. Drug overdose deaths are continuing to plague our community. We see it in the paper every day. Each of us have witnessed friends or family members who have experienced substance use disorder and are at an early risk of a death. And there's strong evidence that there are improvements in treatment that we'll talk about tonight, and techniques for harm reduction that can really save lives. As we develop a universal healthcare system, we know that we need to look at health equity issues, and substance use disorders is one of the areas where populations like Alaska Natives and American Indian peoples are at a greater risk and are dying in larger numbers. So developing a universal healthcare system that includes the equity steps that can overcome those barriers for those populations are important. And that really prompts my thoughts about a land acknowledgement. I'm participating from the land of the Coast Salish people. So please take a minute to acknowledge peoples in the lands wherever you are joining us today. And I see we have people from several different parts of the outside of Washington State. We acknowledge the ancestral homelands and traditional territories of the indigenous peoples who have been here in our homeland or in our state since time immemorial. And our efforts to achieve healthcare for all includes universal healthcare coverage for the Coast Salish peoples of the land which touches the shared waters of all tribes and bands within the Duwamish, Muckleshoot, Puyallup, Suquamish, and Tulalip nations. And so let's get started. Let me bring up Brad, and why don't you introduce yourself? We've actually introduced you through our promotional materials, so I think people know your work, that you're working, coordinating efforts across Seattle and King County, but also you've been a leader in a number of new programs that are making a difference. So why don't you make an opening statement, counselor?
Yeah.
How does that sound?
That sounds great. So first of all, just Ronnie, thank you for reaching out and inviting me to be here today. Thank you to everybody who's here today. I'm honored to be in this space and to have the honor to be able to have this conversation with you all today. As Ronnie said, my name is Brad Finegood. I prefer he, him pronouns. I work for Public Health Seattle King County, and I get the privilege and the honor of being tasked with the responsibility of planning, coordinating, and implementing programs around overdose prevention for King County. That often puts me in the position of working across the state of Washington with our partners at the Department of Health, with the Healthcare Authority, and with many other health jurisdictions and human service agencies across the county and across the state. A little bit of my personal background, because I think that's really important, is that I've been doing this work for in some form or fashion for the past 25 years. I have a master's degree. My master's degree is in counseling, not in public health, but it has a specialty in substance use disorder. I've been involved in the treatment of individuals with substance use disorder for the past 25 years in a number of different settings, from outpatient settings to residential settings to settings of incarceration, in carceral settings like jails and prisons, to outpatient settings. Currently, I've been in my current role at public health for 6 years. Prior to this, I was responsible for our Medicaid system of care in King County and coordinating all of the Medicaid treatment for people with substance use disorder and some other behavioral health conditions also. And so I've been doing this work for a long time, but I think what's most important that I bring to the table is I'm the survivor of a brother that died of a drug overdose. So for me, this work is very intellectual and educational and professional, but it's also very personal. My brother died on New Year's Day this year. It'll be 19 years ago today. He was 26 years old. His name was Greg, and Greg with 2 G's. He would make sure to want me to say that. And I say that because we are the face of the people who are suffering. We are the face of survivors. Every single person who's out there who's suffering with a substance use disorder today is not just some other person. It's somebody's kids, it's somebody's kid, it's somebody's brother and sister, and they're connected to us some way. And so when we talk about people today, we'll talk about what works, what doesn't work. We'll also talk about how many people are out there struggling. But just to know that where that comes from is not numbers and not other people. Where that comes from is really a place of individuals, and that every individual out there who's struggling with substance use disorder is a person who, again, is connected to somebody. And, when my brother died on New Year's Day, almost 19 years ago, watching the ripple effects that go through community. And so how we work with people with substance use disorder and how we provide care is extremely important, because we've provided care very differently for many different communities across time. And we have tools that work. And what we have to do is we have to implement those tools that work. And we have to continue to innovate to bring healthcare to people who are out there struggling, because a lot of the research shows that people do want the help. It's just a matter of whether it's the help that we want to give them or whether it's the help that they're willing to receive. And as we know, as practitioners in the field, we have to be able to give people help that they're willing to receive, because if not, then they're going to shut the whole thing out and the care won't be successful. So that's sort of my introduction and my overview.
So I worked, my first job in graduating from pharmacy school in 1970 was in a methadone maintenance program. And that was only one tool that was available at that time. And we've been able to really move forward. So my first question is, what is the current state of treatment for substance use disorder? Like, there's evidence-based guidelines for so many different things. We should be looking at this as chronic disease, I believe.
Yeah, absolutely. I mean, great question, Ronnie. And we share that in common. One of my first jobs coming out of undergrad was also in a methadone clinic as a counselor. And so, seeing how we've implemented treatment, we have some very effective medications, especially to treat opiate use disorder, between buprenorphine related products and between methadone. And those are implemented very differently in this country. Methadone, people may or may not know, has to be implemented in an opiate treatment program, in a standalone program that people have to come to, especially in the beginning, every single day to receive services and treatment. And methadone is really, the history of it is really started around treating very urban populations, very communities of color, and really trying to mass treat people in a way that was not individualized in their healthcare. And there's remnants of that today. But I think I want to take a step back, if that's okay. And before we even talk about what works, I'd really like to talk about what's happening in the community as far as drug use goes. So I would like to empower people by showing them some data, if you will, and some tools. So can you all see my screen? Is it maybe
Google? Let me see the Google.
Yeah, cool, perfect. Okay, so I'm gonna take you all on a drive through our on a ride through our website. So our website on around overdose prevention is kingcounty.gov/overdose. And I'm taking you here because I am really proud of the work, right? And so this is available to everybody. The data that I'm about to show you everybody is data that is available to you. And it's real-time data. We are one of the only places across the country that provides real-time data on overdose deaths and non-fatal overdoses, and breaks it down by a number of categories, which I'll walk everybody through. But I take a lot of pride in this. This is work of a close colleague of mine, Dr. Julia Hood, in conjunction with our medical examiner's office, and our former medical examiner, Dr. Richard Harif, who recently retired, really championed this work, and felt really called to the mission, because as you all know, medical examiners get folks when they die. And Dr. Harif, our amazing medical examiner, was really wanting people not to die. And unfortunately, more and more people die. So I'm going to take you on a little tour of what's happening right now in our community, the changes in the trends and the changes of overdose. And then I'll talk a little bit about what works. So again, this is King County data. Statewide data isn't available in the same way, all that type of stuff. In this upper right-hand corner, you will see the number of overdose deaths that we've had in King County. When I came to the county about 10 years ago, we were hovering at about one overdose death a day, just less than one overdose death a day. At that same time in 2015, 2016, heroin was the number one involved death. Prescription opiates were the number two involved death. And so we had this, task force that we set up to try to address overdoses. Well, what's happened, especially since COVID happened in 2019, 2020, is overdoses have gone up, have increased exponentially. So when COVID hit, we started to see a vast increase in overdose, and I'll talk about what was driving that. And we started to see, you know, you can see in 2019, overdoses went from 422 to 2020, they increased by about 70. And then from 2020 to 2021, we had approximately 200 more people died than the year before. 2021 to 2022, approximately 300 more people. So last year we had 1,000 people die of drug overdose in King County. That number tripled from just a couple of years before. When you mouse over this and you can play with this, you can start to see what's going on in people's systems, right? So approximately 50% of all overdose deaths in our community had an opioid and a stimulant. So primarily and primarily fentanyl in their system. About half of all overdose deaths. But what I'll tell you though is almost. Let me slow down for a second. So I'm going to take you to this bottom right-hand corner, and you can see the drugs in people's systems at the time of death. So again, going back to 2015, 2016, you know, heroin was the number one drug of choice. Prescription drugs were also killing people, but not at a huge, I mean, at a significant rate, but not at a overwhelming rate that it is now. In 2015, so 7-8 years ago, we only had 3 fentanyl related deaths in our community. So what we started to see was a significant increase in stimulants, right? And so methamphetamine, there's been a lot in the news about methamphetamine, you know, changing the way, you know, we crack down on methamphetamine and home production. And methamphetamine really went to mass production, and it went to a synthetic production mechanism. And we saw a lot more methamphetamine in our community. At the same time, we saw this huge increase in fentanyl-related overdose deaths. So again, in 2015, we had 3 fentanyl-related overdose deaths. Last year, in 2022, we had 713 fentanyl-related deaths. Last year, fentanyl accounted for about 70%, over 70% of all drug overdose deaths. This year, we're definitely on pace to break the how many people died last year, to increase that number. And this year, fentanyl is involved in about 80% of all overdose deaths. So the number of people who are dying are significant. So fentanyl, like, what about fentanyl? So fentanyl is coming in our community in a couple of different forms. It's coming in the form of these counterfeit pills, and those counterfeit blue pills that are coming in our community. I can show you guys pictures in a second, but look like fake Percocet. They have a M on one side and a 30 on the other side. They look like a fake M30. They're light blue. When they first started to come into our community in 2017, 2018, they were selling for like $40 a piece on the street. Right now, people can get, we heard last week that people can get fentanyl pills for 80 cents a piece. So the price is extremely low. The addiction potential, the potential of the opiate is extremely high. Half-life is really short, so people have to use over and over and over. And people are dying, right? So people are dying at a huge rate. So who's dying is the question, right? So when we take this dashboard and we look at trends over time, we can start to look at who's dying. When we look across the county, one of the things that strikes me is we would think, because, you know, these pills are coming in. Oh, the other thing that I just want to say real quick is when pills and powders were starting to come in, or with fentanyl, it changed the route of administration needed to use drugs. So people didn't need to inject heroin anymore, but people have been smoking fentanyl. So some of the like chronic comorbid conditions that people see with injection wounds and stuff like that, we saw a lot less of. People were using fentanyl via smoking. So when we look at who's dying, one of the things that we look at is age. So when we look at the age categories and we look at the rate of folks who are dying, one of the things that's really interesting to me is that we have an older population that's dying of fentanyl, of overdose and fentanyl use. So why is this important to you all? Is because these are also people with a lot of chronic comorbidities. We see a lot of people who are dying who have other types of comorbid health conditions that they need being taken care of, and are using fentanyl and dying, and it's really really scary. A couple other things real quick about who's dying is we know that fentanyl-related overdose, Ronnie, as you said, is impacting American Indian, Alaska Native folks more, is impacting Black populations more at a disproportionate rate. In fact, American Indian, Alaska Natives are dying at about 8 to 9 times higher rate when you look at the crude rate versus white individuals. The last thing I'll say real quick about who's dying is fentanyl and methamphetamine are really impacting our unsheltered populations, people who are unsheltered, so people who are living outside and people who are living in some type of supported housing, because we can get people into housing. If we can get people into housing, that doesn't necessarily cure their substance use disorder. And so we have to be able to treat all these social determinants of health and all these chronic conditions, right? So I think that that's really important to look at. I guess one last thing I'll say is that if we had 1,000 people die last year of drug overdose, we had about 6,000 people that EMS responded to opioid overdose specifically, and were able to reverse overdose. So it's really important to think about like and that doesn't even count people who reverse overdose with naloxone, that where EMS wasn't a part of that situation. So the situation is huge. The situation is big. And these are all, substance use disorder is a diagnosable medical condition, and especially opiate use disorder can be treated with some really effective medication. So part of the pre-conversation that we had were around 2 and buprenorphine, also Suboxone, is an extremely effective medication that works to treat opiate use disorder. One of the doctors was talking earlier just about how they started prescribing Suboxone, and people have never felt so good, because we know that with opiate use disorder, people are using substances because of the withdrawal symptoms, and to stay well and to not be sick. And so we have opiate agonist medications like methadone, partial opiate agonist medications like buprenorphine. And then the last thing I'll say is that we also know that people who are using fentanyl, because of how potent the fentanyl is, because of how short the half-life is, in order to start using buprenorphine, people have to be in some level of withdrawal. They can't be in active use. They have to be in some level of withdrawal, or it throws them into precipitated withdrawal. That's really hard for a lot of people, because they don't want to be in any type of withdrawal, because withdrawal is just like the worst flu that somebody ever had times a million. So one of the things that we've been experimenting with and using a lot, not experimenting with, I'm not a medical provider, I shouldn't say that, is using long-acting injectables. So there's amazing long-acting injectables like Sublocade, which is a long-acting Suboxone product, buprenorphine product that can be injected into somebody's underneath somebody's skin subcutaneously, and will be there and bioavailable for a month. And why that's really important is because Suboxone is a medication people have to take 1 to 2 times a day to continue to take, and especially if we have people who are living unsheltered, have other types of chronic conditions where it makes it hard for them to take their medication, a long-acting injectable might be appropriate. There's another medication that's coming on the market now called Brixadi. Sublocade, one of the downfalls is you have to store it it has to at a certain temperature, cold temperature. Brixadi doesn't have that requirement, so it's much more portable in the field. So there's lots of innovations coming out. I'll also say that that there's other countries that use other opiate agonist medications, including prescription heroin and other types of prescription opiate agonists that help. So one of the things that we know is different medications are going to work with different people, and sometimes trying a medication first with somebody, or trying a medication and somebody might not like it, or you have to give multiple tries to people. One of the programs that we've set up that Ronnie was talking about is a low barrier buprenorphine clinic at our downtown public health needle exchange. So almost all of our needle exchanges now have co-located buprenorphine clinics, because we did, along with University of Washington, Alcohol and Drug Abuse Institute, Public Health, we do a statewide needle exchange survey every 2 years. And one of the things that came up in the needle exchange survey is people want services, they want treatment, but they just don't have access to that treatment. So what we have to be able to do is open the doors far and wide and go to where people are already at. So we opened up a low barrier buprenorphine clinic, no strings attached, come right in, treat you on demand. And that buprenorphine clinic was filled within days, right? Because people want treatment, they want services, they don't want to be sick. And what we have to be able to do is get them other care. The last thing I'll say around what works and innovation is, in King County, many of you probably know that we passed a levy a couple months ago for some crisis care centers. What we have to be able to do in our system is open the front door far and wide, right? If we turn our back on people, then they may never come back. Our systems of care don't do well to engage people in a way in which they're willing to receive treatment. A lot of people who have had overdoses have been traumatized by their care in the past, have been traumatized by stigma. Often emergency departments have traumatized people before. And so what we have to do is we have to create low barrier, trauma free, really safe places for people to go. There's a question from the mayor about, can you define low barrier? Yeah, so low barrier means no strings attached, right? So when I think about, I'll play the high barrier, low barrier game for a second, not game, but comparison. So when I think about high barrier treatment, I think about having to call and schedule an appointment for 3 days out. When I think about low barrier treatment, I think about being able to walk right in. When I think about high barrier treatment, I think about having to get a referral from a doctor to get a prescription. When I think about low barrier treatment, I think about being able to walk right in. When I think about high barrier treatment, I think about you have to be abstinent from drugs if I'm going to continue to see you. When I think about low barrier treatment or harm reduction sort of service treatment, it's I'm going to treat you with this very safe medication and honor the fact that maybe you have been reducing your drug use and that's better for you, and we're going to work towards our common goal. When I think about high barrier treatment, I think about having to be sort of re-traumatized by the experience and having to, when you walk in, the shame and stigma that, because remember, when people use drugs, there's shame and stigma attached to that, right? They're not proud of that. They don't love that. They know that it's having a significant impact on their life. So when I think about low barrier treatment, I think about that unconditional positive regard of like, however you present today, I'm going to help you. So hopefully that says a little bit about it.
And you've talked about them having clear guidelines, having real improvements in care, using buprenorphine first because of its safety factors and the fact that we don't have to see the patient every single day. We can give a little bit larger supplies and not be as worried about overdose. Does the new information you just shared or have learned recently about the broader use of fentanyl, do these guidelines take into account fentanyl use?
Yeah.
Certainly,
yeah,
it's a different narcotic. It's much more potent.
Yeah.
That's I think one of the scariest parts about it. People don't know that going from 1 to 2 tablets is like going from 10 milligrams of morphine to 100 milligrams. Is in a real potent drug like that. How can a kid control that?
Yeah, I mean, they can't, right? And part of the problem with fentanyl and fentanyl pills, so I'll say that fentanyl's coming in our community in 2 forms. One is in counterfeit pills, right? It's not even laced pills, they're counterfeit pills. And those counterfeit pills are running about 1 to 3% purity of fentanyl. We're now starting to see fentanyl come in the form of pure white powder. So it's not laced cocaine or laced methamphetamine if it's in a brick form. it's fentanyl with filler, and that's coming in the form of 15 to, it's coming about 15 to 40% purity. So the irregularity is wider. The ability to control dosage is so much more. So one of the things that you mentioned, Ronnie, is about this precondition of you have to go to counseling also, right? We know that we in the medical community for a long time, the state law is regulated that if somebody wants buprenorphine, A, they can only get it for 6 months, and B, they have to go to counseling, right? But we know that the way that the opioid receptor cells work and how it hijacks your brain, we have to lead with medication first to provide stability. So what you said when you were talking, one of the things that when you talk to doctors who are doing buprenorphine, and especially those who are treating people who are using fentanyl, one of the things we know is that it's really hard, as I said, to get people started on buprenorphine. So we're trying to use innovations to get methadone out. So in addition to opiate treatment programs, we have a couple of mobile methadone vans now that we're trying to deploy into the community. It's harder to access, but one of the things is we made methadone much more available. When I started, 6-7 years ago, I think we had 3 contracted Medicaid methadone providers in the county or locations. Now we have 8 or 9 with 2 mobile vans, right? And so making methadone more available. There's also federal legislation out right now around making methadone more available through a pharmacy model. Up in Canada, methadone purely through a pharmacy model. And it works tremendously to get that medication out to people. Methadone is a pure opiate agonist, has a little bit more probably risk associated with it. But one of the things that I'll tell you is that everything is changing, right? The game is changing. Where in 2015 we had a couple hundred heroin-related deaths. This last year, I was looking at numbers today. We only had 25 out of our 1,000 deaths. We only had 25 that had heroin in it, and 19 of those 25 also had fentanyl in it. So we know that the drugs that people are using are much more potent. It's often much harder to get people started on medication. But we also know that other social determinants of health, like housing and economic stability, are so important for people to have that stability as they go.
So let's save a couple of those questions and talk about my questions first. No, just to kind of get a full source of information out there to people. Let's talk about harm reduction and antagonists programs you have that King County has set up to make naloxone more available. And it seems to me a critical issue with a super potent drug like fentanyl.
Yeah, I mean, great question, right? So naloxone, many of you probably understand and know what naloxone is in this community, but it's this amazing overdose antidote drug. So I equate it to naloxone, or the brand name is Narcan, is like kryptonite for Superman, but Narcan is good. And an overdose is bad, right? And so it's this amazing drug when if you find somebody and they are in the beginnings of an overdose, or if they're in the process of overdose, which is respiratory depression, right? So opioid overdose is respiratory depression. So it looks like a deep sleep, and it's really hard to wake somebody up from, but there are signs and symptoms of an overdose, right? And if you recognize somebody that's having an overdose and you give them a spray of naloxone or Narcan, you can bring them back from that overdose, right? For a period of time. Super important to call 911. It's super important to get the paramedics there. It's super important to get somebody onto services next, right? But Narcan or naloxone is this amazing drug. And so we've really done a lot to get Narcan and naloxone out. We've made naloxone and Narcan. We worked with the state to make it Medicaid, to make Medicaid a payer of first resort that has no pre-authorization. So anybody with Medicaid, and I think most private insurances, will cover anybody's Narcan or naloxone. In addition, it'll cover family members' Narcan and naloxone, right? So nobody can reverse their own overdose, but you can reverse somebody's overdose if you witness an overdose. So we've gotten approximately 15 to 20,000 Narcan or naloxone kits out there across the community. We have a couple of vending machines out there where people can walk in and without question get access to Narcan or naloxone. We also have a mail order Narcan and naloxone program through King County and Kelly Ross Pharmacy. So people can order Narcan and naloxone. We want to prioritize people who either know somebody who's maybe having an opioid overdose or somebody who uses drugs because they're often in community. But we know that Narcan and naloxone is key to this. It's a key factor and facet to this overdose crisis, but it's not the only thing because it's going to reverse an overdose. But then we have to get somebody that ongoing help, right? And that's often where the medications. And so why this is important for you all is because this is all about treatment, right? This is a diagnosable medical condition. Overdose can be reversed with medical interventions. Our opioid treatments work. When somebody has diabetes or cancer or something like that, and they try some type of therapy and that therapy doesn't work, we don't say you need to get going because you behaviorally did something that was counterintuitive to your treatment plan, so I'm not going to see you anymore. We try something else and we try something new, and we leave that unconditional front door open for people to come back and to get that help, because we know that the most important thing is that people have trust with their caregivers and their treatment providers, and those are the people who they're always willing to come back and get help from.
And one last part of the picture for me anyway is that we often associate drugs with crime, and by stigmatizing substance use disorder people as having a unapproved disorder or chronic disorder, that we are looking down on them and stigmatize it. And we often look at criminal justice system as a way to control that. It seems to me the answer is we need an answer for how we get people off the street, rather than making it a misdemeanor or gross misdemeanor to use drugs in public. What can we do to get people into safer places? Are there programs in King County? Are there international or national programs that we can use to avoid having to throw people in jail, as if that's really going to solve their problem?
Yeah, that's a great question. I mean, we know that if anybody so part of my work history, in addition to methadone clinics, has been working in carceral settings, as I said, in jails and prisons for a long time, because that's how we address this substance use crisis in our community throughout years with the war on drugs, right? It started with the Harrison Narcotics Act, went into Nixon and the war on drugs. And then, if there's one book that I could recommend to you all, it's the book, The New Jim Crow by Michelle Alexander. And looking at the way that the war on drugs has been fought on communities of color, and really using the carceral system as pretty much modern day slavery, right? And that's really been my experience too, about the impact on the community of color, right? I remember working in prisons in the great state of Michigan, and I'd walk in to run a group, a substance use disorder group, and I'm the only white person in the room. And there's 12 other men of color in the room because I was working in a men's prison, and they were all there and taken out of their community because of the impact of drugs on their community, right? And the way that disrupts the community, and that just disrupts how community has intergenerational traumas, right? And so we think about the impact on communities and communities of color, and the way that's happened traditionally. We also know that when people go to jail or are incarcerated, the one thing that we don't want, especially for opiate users, not the one thing that we don't want, but one of the things, a change in philosophy and ethos around the medical system is abstinence-based treatment or a period of time of abstinence can actually increase people's chance of dying, right? How does that happen, right? So you I'm an opioid user. I developed tolerance. This is how my brother died. I'm an opioid user. I developed tolerance. I stopped using for a period of time, whether it is voluntarily stop or forced stop, and my tolerance drops. My tolerance stays at sort of a lower level, and then all of a sudden I return to use. Well, my brain and my eyes think I can go back to what I was using before. My body can't process that level of opioids, and what happens is people die in an overdose. So whether that is like a voluntary period of abstinence and detox, or whether that's a forced period of abstinence like jail and somebody coming out and using drugs. So carceral systems, there's a lot of research and evidence that carceral systems increase risk of overdose, and that's not what we want, right? So we want people to get the help that they need and to be safe. What we're doing in King County and across the state is we make sure medications are available for every single person who wants or needs it in jails. So we offer, if people were on methadone, they can continue their methadone. If people want buprenorphine, they can get started on buprenorphine, continue buprenorphine in jails, and then we give them medication on the way out and connect them to care. But we also know with every type of transition of care, people fall off and are at risk of overdose. So we have to do more. We have to do better to bridge these gaps in care. We have to do better to get people access to care, so the criminal legal system doesn't become our default. Because if the criminal legal system is our default, and I get it, people don't want to see visible drug use, right? People like I've seen people using drugs on the street, it's something that we've seen recently. We have to create systems of care to treat those people better and to engage those people, because if all we have is the legal system, then our default is not a health system approach, right? And could cause significantly more harm for people. And so we're trying to innovate. We're trying to do things like we're working with Seattle Fire Department around an overdose response unit. In Seattle, we're setting up an overdose receiving center, a post-overdose receiving center. So a place where people can come that's not a hospital-based setting, but a low barrier access to care. We're working on things like the crisis care levies. We're trying to bring treatment and services more to people in the field so that we can lead with the healthcare system response. So again, we don't have to default back to a criminal legal system response that where there can definitely be a lot of negative side effects from that.
And great. So we are getting some questions in the chat. Let's take a few minutes to kind of put those together. And I'd like to invite Peter Lucas to come up and join us and to really talk about the possibility of donating to our organization. And in the chat, please add any questions. Brad and I will look at those during this short intermission here, or interlude, and then we'll come back and answer some of those more specific questions. But Peter, can you take us on the next step?
Sure. Am I unmuted?
Yes.
Good. Well, Brad, that's a fantastic presentation. And as a practicing psychiatrist who has prescribed Suboxone for years as part of a MAT program, I can really appreciate the soundness of your program. It's really solid. But my job tonight is to make a plug for Healthcare for All Washington. I've been a board member for quite a few years, and we've chalked up many legislative victories in Olympia, including helping to establish and appoint members to the Universal Health Care Commission. And this is a group that could craft a publicly financed universal system based on our bill, the Washington Health Security Trust. And we were very active in the most recent legislative session, and many of the progressive bills we supported and lobbied for were passed, fortunately. And if you want to get the details on those, you can get an update on our legislative tab by going to the legislative tab on our website. But in order to maintain our momentum and keep going into 2024 and beyond, it is vitally important that we meet with our legislators, grow our membership, educate the public, and mobilize our supporters to spread the word about universal health care to their families, friends, and most importantly, those in power in Olympia. And we can achieve those goals through the hard work of our lobbyists and communication specialists, social media, monthly webinars, such as tonight's excellent presentation, meetings with civic groups, and by hosting other events. Financial support of our staff, as well as our other activities and obligations, all require funds, which is why we're asking you to donate tonight. And our goal tonight is $250. And Ron has put into the chat several times the link to make a donation, or if you can't get to it right now, you're welcome to come back to our website and make a donation on there. And you can make a one-time donation, but we would especially appreciate it if you could make monthly recurring donations. That can really help support us throughout the year. So please donate so we can spread the word and bring about universal publicly financed healthcare in Washington. And we are making real progress, but there's still much more to be done, and you can help. Thank you.
Thank you, Peter. So let's wrap up with a few individual questions, Brad.
Yeah, I can just chip at them if you want.
Yeah.
Yeah. One of the things I also want to talk about, an innovation that we're working on that Peter reminded me of, is we're standing up a 24/7 buprenorphine teleprescribing line in the county. During COVID, the federal government relaxed regulations. There's an act called the Ryan Haight Act that came out of sort of Florida pill mills from 15 years ago that precluded a lot of the teleprescribing. They relaxed a lot of that during COVID, and it brought a lot of access to medication for people. So in January, we should have a 24/7 buprenorphine access line, so anybody can call, get access to a prescriber to get medication on the spot 24/7, whether they are a loved one by and near somebody trying to get access to medication, or whether they are themselves sitting at home, or whether there's somebody coming out of incarceration and need that transition. So that's just another avenue in King County that we're trying to explore to provide even lower barrier access to people. And then we can take the first question. So preventing overdose is critical, Ellen said. Please also discuss medications for traditional opiate prescribing drugs and heroin. Do these treatments work as well for folks who use it? And I think we've answered that. In fact, that probably methadone and especially Suboxone might even work a little bit better for drugs like heroin or other types of prescription opioids that are lower in potential or lower in effect than lower opioid effect than fentanyl, because of the withdrawal symptoms that have to happen, especially for heroin. And so we've seen a little bit more success with people using methadone, but it's also hard for people to stay on methadone because they have to come into a clinic every single day. So, but yes, they're both opioids, and opioid agonist medications work. One of the things I just want to point out real quick is that we've sort of changed terminology. We went from this medication-assisted treatment terminology to medications for opiate use disorder vernacular. And the reason is because we don't necessarily see methadone and buprenorphine anymore as the assistant to treatment or the ancillary to treatment, but we see that as the treatment. So it's their medications for opiate use disorder. We don't call insulin medication assisted treatment for diabetes. We call insulin the treatment for diabetes, right? And so it's the same type of thing. John asked about, isn't methadone more addictive than heroin? And that's a sort of a tough question. Luckily, there's smarter people than me on the call, pharmacists and doctors. But what I would say is that methadone is I think one of the problems with heroin is that it has a shorter acting half-life and has an irregular supply, right? So you don't know how much drugs you're getting in heroin, of the opioids. You don't know what else you're getting in, and the half-life of it is much shorter, so people have to use more and more often, which creates this sort of cycle of repeated use and addiction, where methadone has a 24-hour half-life, much more stable. You can take methadone and be okay for 24 hours. So because of the half-life, that has and the way that and how long it stays in your system that impacts the addiction potential. Ronnie, you're a pharmacist. Did I describe that halfway?
You did well. It's certainly, when you compare buprenorphine and methadone, the advantage of buprenorphine is that it's not as fatal. If your next door neighbor takes it from your medication cabinet and takes all of your buprenorphine, or takes some of your buprenorphine, they're not going to die as readily as they would if they took some of your methadone. It's such a strong narcotic. But I think the key is getting people into treatment, as you've said, and with buprenorphine being more widely available or easy for a patient and a provider to develop their relationship around and get somebody involved in treatment. And it's going to have to happen again and again. People that run into difficulty in treatment will still need to be brought in. And so we need alternatives. We need to be able to offer something that might be a little less toxic and a little less chance for overdose, or a little bit safer.
Yeah. I'm going to share two anecdotes real quick, one about methadone and one about the criminal legal system, because they were pins that I wanted to put in talking to you all tonight. So I remember when I started in a methadone clinic, I was 24. I'm almost 50 now, so y'all can do the math, half of my life ago. And I was very blue, or very green. I'm very blue today. Very green in working in this field. And so one of the preconceived notions and stigma and bias that I had about methadone was that it was a replacement or a substitute for heroin or any other types of drugs, and that people should want to get off of it, right? And so I'll share an adage real quick that happened. So there was somebody who came into the methadone clinic. I was their assigned counselor. I only saw them once a month because they only came in once a month. They had been on methadone for 25 years. Right. And I was like, how could you want to be on methadone for 25 years? Doesn't that control your life? So I go to the gentleman and I go, sir, I was like, let's work on getting you off this. He's like, I'm like, you've been on this medication for 25 years. And he goes, let me tell you something, young man. Back when I was young. And he goes, I've been on methadone for 25 years. He goes, I've tried to get off of it 3 times. The first time, every time that I tried to get off of it, within weeks, my urges and cravings are too much and I go back to using drugs from the street. Within weeks of that, my drug use pattern makes it so I'm not home in the evening and away from my kiddo. And after that, I'm committing crimes and in jail. He goes, this medication saves my life. I'm going to take it every day for the rest of my life. Right. And so that just felt so much stigma about the medication, about the myth of methadone, about what my goals for somebody are versus what their goals for somebody are. And so methadone is really about providing that stability. The other thing I want to tell you all real quick is we're talking about criminal legal system response. So I used to do a lot of counseling with people who had substance use disorder who were court involved. Right. And so there's a gentleman who came to me. And he was he had alcohol use disorder. He was a drinker, right? And so he violated his probation one day, and by having a breathalyzer, right? We think these things are going to hold people accountable, right? It doesn't work, right? They just figure out people, the deception, all that type of stuff, right? So he violated his probation by having a drink, and he went in front of the judge, and the judge gave him a weekend in jail. So he came to me for counseling on Friday. And I was like, all right, buddy, you got to go to jail, this afternoon. I was like, let's be intentional about the enlightening experience and be reflective through the process. I want you to journal. I want you to do all this type of stuff. And I want you to come back on Monday and be ready to talk to me about all the stuff that you learned and that you thought about. And so he's like, all right, Brad, I got this. Right. And so he goes and serves his weekend in jail and comes back to me on Monday. And I was like, all right, man. I was like, so tell me, what did you learn? Were you reflective? He's like, man, I learned so much. He's like, I learned how to make methamphetamine in jail. Right. And so we put people who are sick with chronic medical conditions like substance use disorder and other conditions in a place where is not healthy, right? They're around other people who feed the emotional disorder. They feed into the addiction. They feed into all the behavioral health conditions that happen. And we can't expect people to heal in environments like that, right? The only thing that's going to happen, and that adage was so true, is people end up getting sicker. And so to think about, well, if there's other ways to work on that and to process that with him, because we might be mad at somebody and want to punish somebody, but really, is that good for that person or the community in the society? So I just wanted to share those. And I think, there's a lot of good questions here. But I'll take David's question about Narcan nasal spray is available for free. Should we all have a spray pack in your car? Absolutely. I have a package in my house because I have 3 kids who are at home. I don't think any of them use opioids, but I don't want to find out the hard way. I will also say, I don't know, I've been into podcasts lately. The podcast This American Life had a great episode that somebody sent to me called The Call. And let me see if I can find it, and I'll put it in the chat. But if you have a chance to listen to it and spend an hour of your time thinking about the importance of trust and open relationships, and how substance use disorder is a chronic medical condition, it's real. Yeah, David, well done. There it is. There's the Narcan, and that's what it looks like. David, can you open the front? Like there's a front flap on that, and it's super easy. It gives you a 3 or 4 step. On the box. I'm sorry. That's what the Narcan looks like. But on the box, it gives you a 3 or 4 step process. That's super easy. But one of the things that you can do, and you can off of our website, you can also order posters in addition to Narcan, in addition to fentanyl test strips, all that type of stuff. We have posters about what are the signs of overdose. And I can't tell you, there's nothing more important than being able to recognize what an overdose looks like. The day my brother died, the person who was with him, who was also using drugs, didn't know he was overdosing and gave him some bad advice to go back to sleep, and never woke up. And so, in addition to having all these tools, recognizing the signs and symptoms, like any other medical condition, is so very important.
So we will distribute that information. We will make your comments tonight available on our YouTube channel. So if you have friends or family that you want to share Brad's information with, please tell them to check into our YouTube channel later. Usually it just takes a few days to really get that going. I see things showing up in the chat with links such as the podcast that Brad was just talking about. But I really appreciate your time and energy, Brad. Thanks for joining us tonight and sharing this life-saving work.
Yeah, it's a pleasure. Thank you all for having me. As Ronnie experienced, I'm more difficult to get a hold of via phone. But if you have any questions, if you just Google Brad Finegood, you'll get my King County email address. Ronnie has it. Please never hesitate to reach out. I'm a resource for you all in the community, and thank you for the advocacy work you're doing.
And also want to thank people and volunteers behind the scenes. Ron Lovell, thank you, Ron. Rich Legou and D.W. Clark for recording this so we can get it online. But most of all, I want to thank each of you, because just showing up tonight tells Brad and all of us how important this is. Join us for future Second Wednesday Speaker Series. October, we're having a conference or education program that'll be a part of our annual meeting. That will be Saturday, October 21st. Save that date. And then the second Wednesday in November, we will be starting again with another program. Our annual conference will be focusing on prescription drug affordability. We've invited speakers from other states like Oregon, California, and someone to share a national perspective. And in November, we'll be talking about our state's effort to expand healthcare coverage to immigrants. So we passed some legislation in the 2023 session, and we are finally getting some ideas on how to make that happen. So join us in October at our annual meeting, or join us in November on the second Wednesday speaker series. So thank you all so much for joining us. And again, thank you, Brad. Good night, everyone.